I don't have any disclosures, and my objectives today are to explain the purpose and benefits of assisted outpatient treatment, to demonstrate the role of advocacy in shaping mental health policies, to highlight the importance of patients with severe mental illness having equitable access to mental health treatment, and to identify steps we can take to become effective advocates for our patients, colleagues, and communities, and to demonstrate an understanding of why representation is crucial when advocating for mental health programs to ensure that policies are inclusive, equitable, and effective. This talk today is in honor of Ben, as well as our other patients that we have lost who could have benefited from AOT, to our tireless advocates. And again, thank you, Ms. Bennett, for sharing your story. So when I thought about this talk today, there were several titles I could have chosen. One, Three of a Kind, No More, AOT and Advocacy Journey, Why Representation Matters, Dispelling the Myths. My goal, though, is for people to understand what is AOT and how we can help our patients with severe or serious mental illness. I'll give a case study. Kendra Webdell was a 32-year-old photographer and journalist who was pushed in front of a New York City subway in January 1999. Her parents, her community, her lawmakers sprung into action and were able to pass Kendra's Law, which was the first assisted outpatient treatment law passed in the U.S. It provides court-ordered outpatient mental health treatment to individuals with severe mental illness who struggle to engage in voluntary treatment. Other names for AOT include involuntary outpatient commitment, or IOC, outpatient civil commitment, or OCC, which Ms. Bennett alluded to, mandated outpatient treatment, court-ordered community treatment. California has Lohr's Law after another unfortunate incident where someone lost their life at the hands of an individual who was untreated. Until February 2024, Maryland, Massachusetts, and Connecticut were the only 3 states without AOT. So what is assisted outpatient treatment? Assisted outpatient treatment is a tool for civil courts and mental health systems to work collaboratively to help individuals with serious mental illness caught in a cycle of repeated hospitalizations, homelessness, incarcerations. Individuals who benefit from AOT have inconsistent treatment, often due to diminished awareness, or what we call a lack of insight, or a term anosognosia, which we will talk about later. They often do not appreciate their need for treatment. AOT aims to motivate and assist individuals with severe mental illness to engage in treatment and ensure that the mental health system is attentive to their needs. Criteria varies among states, and like I said before, until 2024, we were one of the 3, Maryland, Connecticut, and Massachusetts, who did not have AOT. So how does AOT work? It does vary among states, and here, after filing a petition and if criteria are met, a judge will order AOT upon discharge from a hospital, discharge from a jail, or if a patient is cycling in and out of hospitals and jail, it can be done from the community. The AOT participant is court ordered to follow a treatment plan in the community for a specific period of time. If the AOT participant does not adhere to treatment, then the court, in conjunction with the AOT team, can modify the treatment plan, can have the participant return to court, or can have the participant evaluated for potential hospitalization. The order can expire once the participant demonstrates voluntary engagement in treatment. Is AOT effective? Studies show that AOT can dramatically improve treatment outcomes and substantially reduce the likelihood of repeated hospitalizations, criminal justice involvement, homelessness, substance use, violent behavior, and hospital stays. Most studies show that patients who are in these programs have a 92% satisfaction rate of the program that they're in. These are just some statistics from the Treatment Advocacy Center. In New York City, there was a 77% decrease in hospitalizations compared to the 3-year period before AOT was instituted. Incarcerations were down 87% in this population. Length of stays down by 43% in Florida. Homelessness was down, illegal substance use, and cost savings, which isn't, I think, talked about enough, but Summit County, Ohio showed a 40% cost saving. It's important to note that the APA took a position in 2016 on AOT. Their APA position is that IOC, or AOT, they wanted to make sure that they included kind of the mandated aspect of it, can be a useful intervention for patients with severe mental illness and documented histories of poor compliance leading to repeated relapses and rehospitalizations. It's important to note that around 20% of the U.S. population will experience any mental illness within a given year, Most of these patients seek outpatient care voluntarily in primary care settings, outpatient mental health clinics, private practice. Around 4.9% of these patients suffer from severe mental illness or serious mental illness, like schizophrenia, schizoaffective disorder, bipolar disorder. These patients are often treated in outpatient mental health clinics, like community psychiatry, where I practiced for about 15 plus years. We would discharge some of these patients to ACT teams. Those who need a little bit more support or wraparound or a little bit more disorganized, they would be referred to mobile treatment or to assertive community treatment teams. We also have capitation programs here in Maryland. Chesapeake Connections and Creative Alternatives, one that Ben was part of, and those are for our most vulnerable patients. It was really our highest level of care outside of state hospitals for these patients who really need wraparound services. They are incentivized to really keep people out of the hospital, keep people out of the emergency department, and to treat this population of patients. It should be noted that about 10% of these patients, maybe up to 30, but become this kind of revolving door of patients with severe mental illness. These are the ones who are falling through the cracks and who are receiving their care in our emergency departments. They're receiving their care in the inpatient hospitalizations, in the jails. We do have this pilot project that people can be referred to, which Ms. Bennett alluded to, but we also have our state hospitals where we will find some of these patients who are in unconditional release. But most of our state hospitals are occupied by our forensics patients who are waiting trial for competency or who have been found not guilty by reason. I will admit that as a community psychiatrist, I did not appreciate this crowd. And it wasn't until I was asked to be embedded in the psychiatric emergency department in 2019 that I began to see patients over and over and over again, several times a month, sometimes several times a week. I was questioning why am I seeing people who I admitted, they were hospitalized, they were placed on medication, they would often get discharged within the week and be right back in the emergency department. I questioned why are these patients being allowed to fail? And I questioned what is the monetary cost of this and reached out to our behavioral health carve-out and found that many of these patients were racking up hundreds of thousands of dollars of bills within the year with this repeated cycle of failure. There were several populations of patients that we deemed kind of our high utilizing crowd or our revolving door. We don't really like to use those terms, to be quite honest, and sometimes we refer to as our friends or our friendly faces. And there were several other populations like our dually diagnosed crowd or the patients who were using as kind of a shelter or respite, but the focus of today's talk is that crowd of patients who have severe mental illness or serious mental illness and a severe lack of insight, or what we call anosognosia. So I started to question, why are some patients with severe mental illness falling through the cracks? It was in 2021 during COVID, I was asked to provide a grand rounds. It was virtual, and I started thinking to my patients and just thought, what the insanity of this? Do we need to rethink state hospitalization? At the conclusion of my grand rounds, I concluded that deinstitutionalization, which was a government policy that moved patients out of state hospitals and into federally funded community health mental health services, were failing this population. Many of these patients were falling through the cracks, leading again to repeated acute hospitalizations, incarcerations, homelessness, violence, and increased victimization. I concluded that maybe state hospitalization should be our last resort. It always should be the last resort, but I realized that Maryland was missing a critical tool that could help these patients. I began to question, it was during that research that I realized that Maryland was one of these 3 states that did not have AOT. And I'll be honest, I thought that New York and California were one of a few states that had AOT. So I began to question, why doesn't Maryland have assisted outpatient treatment for this population? I think that's what started my kind of advocacy journey. And per the Missouri Foundation for Health, advocacy is any action that speaks in favor of, recommends, argues for a cause, supports or defends, or pleads on behalf of others. As I continued my work in the emergency department, I began to question, how can I affect this population? How can I affect some change to better help my patients? For the sake of time, I won't go through all of the things that we ended up doing, but I did reach out to some of my mentors, Annelle Prim, Ken Stoller, Jeff Janofsky, to find out what can I do. I realized there was really only so much I could do from the front lines, despite being the director of a psychiatric emergency service at a premier institution. One of the most significant recommendations that I got was that I needed to get more involved with the Maryland Psychiatric Society's legislative committee. And it was there that I was able to realize that AOT bills had been coming up in Maryland for like the past 20 years. But it wasn't really psychiatrists who were driving this. There were some psychiatrists who were in support, but it was mainly our family advocates, the Treatment Advocacy Center, which has been helping other states to employ these AOT programs, and they were involved with the New York's first program as well. And it was there that I realized that many were pushing for this AOT law. And when I went to my first legislative committee meeting with the Maryland Psychiatric Society, the bill came up, the one that Deborah was referring to, the one for Frederick County, and them to want an AOT bill. And I was surprised to learn that MPS was going to oppose or either not take a position. And I started to question, well, why are we not taking a position? And when I was thinking about my patients and how they were failing, and the sole purpose of me joining the committee was to help become a voice in this domain. And I really even said out loud, I don't know if I can remain on this committee if we're not going to at least show some level of support. I was pleasantly not surprised because, we were professionals and we had some healthy debate. And what I realized that there were some legitimate concerns on the other side. And it wasn't that people didn't think this was needed, but there were some concerns about logistics. There was an overall lack of consensus among some MPS members, mainly around the concept of involuntary outpatient treatment and patient civil rights and autonomy. Some were concerned about the logistical complexity of these bills and how could they really be fulfilled. There was concern, would there be adequate funding and resources? And even the APA statement, they said if there isn't adequate funding and resources, then it's not gonna work well. There was also concern that the bill was being drafted by people other than the MPS or other psychiatrists. There was a concern, is there a way to enforce it? And then in some of the earlier bills, there were psychiatrists who were being asked to provide treatment plans without ever having met the patient. Fortunately, that healthy debate continued, and we as a committee decided that it was very important for us to show that we were in support of this type of treatment for our patients. But we did realize that there were some amendments that would need to be added. So the MPS for the first time supported this bill in 2022 for Frederick County to establish an AOT program. We supported with amendments. We had a legislative subgroup. At that time, it was during COVID, and I remember the hearing for the Senate bill and the House bill, and I observed this process online. And the bill failed, and I remember thinking, I was just a little disturbed by what I was observing. And I started looking at who was at the opposition table who were really fighting strongly to prevent a bill like this from passing. There were several, the Public Defender's Office was at the opposition table, On Our Own, which is an advocacy lived experience. They are one of the main sources at the table. Disability Rights Maryland, some psychiatrists had concerns, social work advocates for social change. One of the main points of opposition were this civil liberties and autonomy. Persons concerned that this was violating personal freedoms, coercion, undermining the trust of patients. Most saw self-care as the more efficient than having this mandated aspect. Some were concerned, especially Behavioral Health Systems Baltimore, about the strained mental health resources and would we be diverting funds and resources from other programs, such as the OCC program, which had its own problems because there wasn't enough teeth. It was really kind of voluntary despite saying involuntary, but people could walk away from it, which Ben did. There were also concerns about the legal and ethical implications of AOT. Some question, was it constitutional? Question, was there insufficient due process? And there was also concern that there was a racial discrimination aspect, that there was a fear that Black and brown people and people of low income were disproportionately impacted by this bill. So my takeaways after observing that, again, I was really concerned. And I noticed that, one, there were no physicians or psychiatrists at the table. I noticed that after the discussion was had, everyone kind of picked up their bags and went home, and it was kind of like, okay, off to the next year. I realized that there was some misinformation, I thought, and some problematic testimony that was not being challenged. And I recognized that anosognosia, which we were talking about, did not come up at all because there were no physicians at the table. At that time, I was still in the emergency department, still seeing this revolving cycle of patients who were failing. I was on the other end of phone calls from frustrated families who couldn't understand why I could not either admit their patient or why we didn't have more tools. And I started feeling like I was part of the problem, to be quite honest. And I think I started realizing that if AOT is going to get passed in Maryland, then we're going to have to be more assertive. Don't want to say more aggressive, but we had to be more intentional. And I often thought about Representative John Lewis, who said sometimes you have to get in good trouble, some necessary trouble. He said that if you're passionate about something, that sometimes you have to get out there and push, stand up, speak out, and get in the way of the same way that his generation got in the way. So one, I did want to touch upon this term anosognosia, which is honestly kind of controversial even probably with some in this room. And I think it's worth speaking on because I felt that if people did not put our concerns in more of a medical kind of terminology, that it was going to be more difficult for people to understand the need, why we had this need. Anosognosia is a condition in which a person is unaware of or denies a significant neurological or psychiatric deficit. It's a more formal term for lack of insight. The Greek meaning is to not know a disease. There's often damage or dysfunction, often in the right hemisphere of the brain, in the frontal and the parietal lobes. There's often either neurological, like strokes or paralysis. Anosognosia is seen in that population, as well as our patient population with severe mental illness. Some psychiatrists question if this is really a true phenomena. There's concern that there's potential misuse with this, that patients' rights can be taken away, that they can be forced into treatment because of this term. We know there's not a lot of biological markers that can identify this, and the concern that there's a difficulty in measuring thought processes and emotions that won't allow us to truly state that this is something. But most people do agree that there is something called anosognosia. I noticed that in my patient population, that was the #1 problem, that most of my patients did not understand that they were ill, did not recognize their need for treatment, did not recognize that they were likely going to die early deaths or lead a substandard life if they did not get treatment. So fast forward to 2023, when another bill that Ms. Bennett alluded to came around. This was Senate Bill 480, House Bill 823. And this was for counties in Maryland to establish an assisted treatment program if they wanted to. At that point, I realized that I needed to be more aggressive. I provided written and oral testimony at both the Senate and the House. I encouraged Hopkins to write a letter of support, which we did. I engaged some of my colleagues and some residents who provided written letters of support or provided some testimony of patients that they felt would benefit from AOT. I will say one of our patients who most of us have probably treated, there was a written testimony provided on him, and he died, sadly, a year later. For the first time, this bill was voted unanimously out of the House. I do credit some of that for the House got a new chair for this department, who I think was the assistant chair for many years. And she said, when I get to be chair, this will be passing out of the House, which it did. But it failed to get a vote out of the Senate. At that time, I started to grow increasingly alarmed that maybe Maryland will never pass an AOT bill. I started thinking about other things that I could do to get the word out. I wrote an op-ed in Maryland Matters, which is a legislative publication, and this was before the vote came out, hoping that maybe some legislators would read this and spring into action. I titled this, Maryland Needs Assisted Outpatient Treatment So I Can Save My Patients. And if you look at it, I really did say that I felt like it was unacceptable for Maryland to continue to operate in this manner. Also, I was interviewed by the Johns Hopkins BrainWise. I didn't even know this came out, honestly. I think someone sent this to me saying, did you realize this was published? And I didn't, but it was. So 2024 came around again, and another assisted outpatient treatment bill came around. This time, this was to allow or mandate the creation of an AOT bill in any county in Maryland, with eventually the whole state coming into conformity. Governor Wes Moore championed this bill. He had it part of his AOT platform when he was running for governor. I remember seeing that, and I think in one of the slides I put semi-stalking is one of the things that maybe we have to do. But I remember that I knew he was going to be in Annapolis giving a presentation. I went there after work and I missed him, but his Secretary of Health, Secretary Herrera Scott, was on a panel talking of her desire to become more active in the mental health space, and she understood that there was need there. After that panel, I slipped her my card and I said, you know, I'm really concerned about AOT. I think we need this bill. And to my surprise, she emailed me the next day. I was in her office the next week. We spent about an hour just discussing AOT and why I thought it could be helpful for Maryland. It was interesting, it came full circle because during this year with Governor Westmore championing it, Secretary Herrera Scott actually opened the session with powerful testimony for the need for AOT. Deborah was at the table and was able to give powerful testimony at the governor's table as well, and she talked about that she just lost her son, and that when she was added to this committee, the commission, Ben was alive, and she was advocating for AOT. And then here we are, she's still at the session, but lost her son maybe a month earlier. So Deborah's testimony was powerful. Evelyn, who's here, who's been providing testimony over 20 years. She was there along with her advocates. NAMI was there. For the first time, BHSB was actually at the supportive table, as well as MHA. And they were saying that, yes, we need AOT, but we need to make sure that we do it correctly. MPS and Hopkins supported with amendments. So this bill did pass. And then this is a picture of the individuals, Dr. Elias Shayes, who's here. In my work in the emergency department, I started reaching out, and others were reaching out to me about the same thing that I was seeing, which was these patients who were just cycling in and out, and what can we do? We decided to develop a group called Best Punt, kind of best practices for patients with unmet needs. Dr. Shai is with MedStar, Dr. Van Rimmons at University of Maryland, Dr. Rishi is at LifeBridge, and we all provided testimony in 2024 at the table and gave written and oral, which I think was helpful in getting this to pass as well. I did want to mention as well that Governor Moore, his chief legislative officer, provided powerful testimony speaking to the fact that his brother has schizoaffective disorder and the guilt that he shares because he didn't know where his brother was, and after years of trying to get him help, that he felt helpless, and he was advocating for AOT as well. So fortunately, this bill was introduced in January 22nd, 2024, passed the Senate April 4th, passed the House April 8th, and was signed into law on May 16th. And Deborah and Ms. Burton and Dr. Shai and our Best Punt crew, Secretary Herrera Scott, we were all there for the bill signing. So the bill was signed into law, but now there's a lot of work that has to be done in the aftermath. July 2025 will be the time that the law will take shape, and counties will be able to opt into establishing their own AOT program, but in July 2026, all counties must have an AOT program, and they will have to work with the state in order to help them get a successful AOT program. It's important to know that this law will sunset in 5 years, meaning that it can go away, and the people at the opposition table will likely be ready to see it go away again. So it's going to be very important for this program to be rolled out successfully, for us to be able to show outcomes like the earlier stats that we showed, and for patients to really receive benefit. Myself, along with Dr. Shai and our Best Punt crew, have been asked to be part of an advisory council where we meet monthly with the state and Secretary Scott and her team to really provide that clinical expertise that we think is going to be needed in order for this to be successful. It should be noted that there is a bill that we are advocating for that adds a restriction for firearm possession for patients who are on an AOT certificate. We do need to work together because there is some concern to make sure that, one, we want to focus on the fact that this population has an increased risk for suicide, and that they have a significant risk, and that if there's firearms possessed, that they're at increased risk, and we want to lessen the violence aspect. And we also want to make sure that this doesn't become a reason why people do not seek to petition patients for fear of gun rights and all that we know that comes with that. So I wanted to briefly talk why representation matters. When I look back at that 2022 bill, when there were no physicians or psychiatrists at the table, It wasn't really until NPS came on board that I think helped to kind of spur along. If you have a bill that's coming up and you don't have your largest psychiatric group in the state supporting it, then it's really likely not going to pass. So I think it was crucial for NPS coming on board. Not only psychiatrists, but I felt community psychiatrists. It's us community psychiatrists who are seeing the patients in our clinics, so mostly are doing well, but we have the ability to send them to ACT teams, capitation programs. But for me, it was not until I was embedded into the emergency department that I understood the significance and why AOT was needed. So we need representations from psychiatrists at multiple levels. I think me being an African-American psychiatrist helped. I mean, I just was steaming sometimes hearing people advocating and saying for people who look like me what they were advocating for, but I was like, no, people who look like me really need this. And I was asked several times by Evelyn when it was coming to the last straw that can you call this lawmaker? You know, they're concerned about the racial aspect. Can you give them a call and dispel the APA part of their position statement? They looked at the racial concerns and determined that there was no disproportionate racial matter. And sadly, because of systemic racism and things of that nature, we know that there is just an overrepresentation probably for other factors other than AOT. We needed representation of families, and we also needed representation of patients with lived experience who were doing well in AOT programs. Evelyn gave me permission to state that one of her family members has to live in another state where they have a thriving AOT program, and she couldn't keep him in Maryland because she was concerned he would fail. So we needed patients with lived experience who were able to counter the other lived experience that was at the opposition, who were saying that this involuntary commitment is horrible and should not be done to anyone at all costs. So this is Senate Bill 453, and I'm looking at the time, but this is the Senate bill if anyone wants to look it up. But I'll briefly say that if someone is concerned about a patient they have who they think would benefit from AOT, then any director of a specified mental health program can become a petitioner, or any individual at least 18 years old who has a legitimate interest in the welfare of the respondent can petition. Similar to emergency petitions and even our ARPO petitions. But the petitioner has to have reason to believe that the respondent meets criteria for AOT, and they must have factual allegations for each criterion. The petition must be filled out in circuit court, and it must be accompanied, this is an important piece, by an affidavit from a psychiatrist who has evaluated the patient within the last 30 days, who is willing to testify and speak to why this person needs AOT. Then a care coordination team is assigned. There is then a hearing, and actually one of the stipulations is that patients who were referred to this do have the opportunity to agree to voluntary treatment. I know some of our advocates were concerned that this might lead to what we've already had, this voluntary nature that people don't pursue. However, given there's going to be a mandated team that will oversee this, if that person agrees to voluntary and then fails, then there will be a mechanism to bring them back in to make sure that this moves forward. And the psychiatrist has to agree to provide testimony. In order for this AOT order to be put on a patient, there has to be clear and convincing evidence that the respondent is at least 18 years old, that they have a serious and persistent mental illness, that they've demonstrated a lack of adherence with treatment for this illness, and that they need AOT in order to prevent relapse or deterioration that can put them or others at harm. The respondent is unlikely to adhere to outpatient treatment on a voluntary basis, has to be one of the criteria, and this has to be the least restrictive way to treat them. So again, this is still kind of a work in progress. I'm happy to be part of the advisory council along with some of my colleagues, because it's really going to take a village, and it's going to take a lot of work to make sure it's done successfully, because the opposition is still out there and it's pretty staunch. I did want to include some pictures just from this advocacy journey. A picture with me there, that's part of my Best Punt crew with Dr. Shaya and Dr. Rishi and Dr. Van Rimmen. This other picture is Secretary Herrera Scott. This was from the day that we all testified on the Hill. This is part of my advocacy journey with Ms. Bennett and Evelyn at the Treatment Advocacy Center dinner, where this is when AOT was still in the process of hoping to get passed. This is on the governor's signing day. These are some of my legislative committee members in our days in Annapolis. I think Paul Nestat's here. I think Katie Blair. I'm not sure, I can't see my glasses, I can't see who else is here, but this is our legislative day in Annapolis, where actually we just went last week to talk about the bills that we're supporting this year. So I wanted to say thank you for all of my colleagues. ED leadership, I must say I didn't get to speak about what we're doing with our high utilizing population, but we have care coordination, our PES social works, nursing. I see one of our social workers, Kaltari, here. We've all been really working with this population in general, not just our severe mentally ill, to see how we can decrease ED recidivism. Thanks, Dr. Small, for presenting, as well as Catherine Brody, who's not here, and Tom Sedlak, who provided written testimony. Secretary Laura Scott, who's not here, my Hopkins colleagues, and I will say it's been nice to be at an institution that has really allowed me to go out into the community and advocate. I know that others are kind of put a little bit more restrictions, and I appreciate you, Dr. Potash, for allowing me to go advocate for our patients. I think this is a necessary tool, and I'm hoping lives will be saved, because we have lost too many lives prematurely who could have been saved by AOT. Thank you.
Thank you, Dr. Lewis. Wow, what an impressive thing to have gotten this across the finish line. I think it's an incredibly valuable tool, potentially. I say potentially because it hasn't been implemented yet, and I guess on the implementation front, I guess my question for you is, are there things that you've learned, or that the whole community has learned from looking at implementation in these 47 other states? Are there particular things that are necessary to make it work when you put it into action?
Yes, that's a great question, because although there are 47 other states before Maryland that have programs, there's only a few that are really successful. And if there's not really a push for resources, I know this bill was attached with a $3 million fiscal note to try to support the program and the structure. But there's also, if you don't have the resources, if you don't have people who are truly wanting this to succeed, then it's not going to succeed. So I think it's going to be important that we not only got the bill passed, but that we're very assertive and intentional about making sure that it's successful, making sure that it is rolled out successfully.
That makes sense. Thanks. Other folks have questions. Dr. Sedlak. Maybe I'll just repeat the question for people listening online. Have we learned from other states about potential capacity limitations?
I think so. I think New York probably has the best structure right now, and they have a hospital that's really set aside for these patients, where if a patient is in need of hospitalization, they can go for like a 4-month stay, get reacclimated, have their team treat them, and really help to get them back out in the community. One of the things that we've talked about on the advisory council is that there's, I think, 2 things. That if patients are not provided adequate housing, and if they are still homeless, that it's going to be very difficult to be successful. Also, right now, we really don't have identified places that will actually take these patients for a longer period of time. I would advocate that, I would love to run like an AOT unit somewhere where we know that patients who are brought into the emergency department who are on an AOT certificate, that instead of them staying in the emergency department for excessive days or looking for an acute hospitalization, that there is a unit set aside for them that is dedicated to treating them. In the advisory council, we are talking about the homelessness piece and the hopeful need to provide these beds, but right now there is a shortage of beds. It's a major issue, and I really do think if people, that there are resources out there, and there are ways to make this happen, and I think if units could be incentivized not for that shorter length of stay, but could be compensated for taking care of certain populations, it could work. I think it's really, do people have the desire and the motivation? The resources there, we're spending hundreds of thousands of dollars on all of our residents have seen our friendly faces, and I actually was able to get some numbers attached, and $500,000 here, $400,000 here. If we reallocated those funds, then there could be means. So I think it's where there's a will, there's a way.
That's a great point. Other questions? Dr. Taylor. what sort of data do you think you would need to demonstrate this is working if new funding opportunities come available in the future?
Yeah, that's a great question. And I think it's the data that is shown in New York City. I mean, when I looked at what made me question these patients, we need to show that there's decreased hospitalizations, which cost millions of dollars, decreased interaction with the police, which data has shown millions of dollars, decreased ER visits, where a lot of these patients come to the ER and then get discharged because we don't have the beds, improved homelessness, decreased victimization, decreased deaths. Sadly, I think a lot of people are dying and not being shown that they would have benefited. I think your son with the overdose, he could have got labeled as an overdose as opposed to someone who would have benefited from AOT. So I think it's those same data points that New York shows and that we need to show here. I'm really hoping to work with some of our residents to look at, I've identified maybe 10 or 15 patients, maybe 20, that I will refer to AOT as soon as it comes out. I would love to look at how many times are they in the emergency department, how many times were they hospitalized, how many emergency petitions, and then do they were the intervention AOT, now the post-vention, and are we showing a decrease in those numbers? So everything that we alluded to, that's millions and millions of dollars that can be saved. And if people really want this to continue on, they can look at that data and see that, oh, this is very helpful and makes sense.
Mm-hmm. Great. Dr. Stoller.
That was terrific. Thanks so much. I was really impressed with our guest's statement about the importance of peers, and also you're mentioning that groups like On Your Own weren't initially supportive. I'm just wondering whether groups like On Your Own and NAMI and some parent groups, are they on board now? And if not, is there anything we can do to make sure they're on board so that they can support this, refer into it, and maximize its outcome?
There are peer support and other advocacy groups on board.
Yeah, that's a great question. I will say that part of the bill, there has to be a peer support specialist, part of that AOT team. In order for this to pass, people really had to come to the table and compromise. On Our Own still was not on board, but they were agreeing to be a little bit more open-minded, and when adding the peer support, that helped them to get a little bit more on board. They did not support, but they did not give as much pushback. Also, giving patients the opportunity to voluntarily agree to this program first, which again, some of our advocates, people had to then say, well, look, we can't push for, that had to be in there, because I think in order to get their support, not on paper, but just for them to say, maybe we'll let this go through, giving people the ability to maybe do it voluntarily at first, that was part of it. So the point is that we see right now, just in our society, that people have to come to the table. They have to come and reach some reasonable compromise, and you have to really think about can you give up, what can you live without? And it's really that peer support, which even our patient who we lost, who someone gave written testimony, he had a peer support specialist for a period of time and did very well. And it was that peer support specialist that kept him in treatment for his medical care, and then when he lost that peer specialist, you could see the decline, and then he was deceased not too long after. So peer support specialists are important, but they have to be part of the team and making sure that they're on board with the involuntary aspect, that treatment medicines might be needed. Everyone has to kind of be on board and advocating for the same thing.
Thanks. No more questions. There's always so many more things to talk about, but thank you, Dr. Lewis. It's just so encouraging to see a program that can really make a big difference going forward. Thank you.
Thank you. And the last thing I wanted to say again is that our advocates, our family advocates, and our NAMI mommies, this bill would never pass without their advocacy tirelessly over these last several decades. So thank you.